Okay, so we all are humans, so we all make mistakes, and basically we are discussing three most commonly made mistakes, or the diagnosis in which we require a very careful, keen eyes, and the clinical evaluation for the diagnosis and treatment. If the diagnosis is wrong, then whole process will be wrong. The patient will be unnecessary harmed, and they will be landing up in trouble, and so we may also land in the trouble in these situation. Okay, so common mistakes in the diagnosis. It is There was one study done by Lisa Omeri in 2023, and they have published this also, and they have said that there is about 11% of the medical problems are misdiagnosed, and the misdiagnosis of medical problems basically depends upon variety of disease. And according to their study, they have found out that the most commonly misdiagnosed problem is spinal abscess, and it was 62%. And least common misdiagnosed condition was heart attack, and it was about 1.5%. So with this note, let us go through the case. Okay, so case one. So these all of these cases are the real cases which I had come across in my clinical practice. Okay, so this was a case of a female of 68 years old lady came to me in about 4 years back in October 25th, and I was very new. I just graduated from Daradia, and I was practicing pain in one of the hospital. Previously, I used to work as an anesthetist as well as pain physician, and this was one of my few first cases, which was very interesting. And with this case, I was motivated to continue pain physician career even more. Okay, so 68 years old female came to the operation theater because I was working as an anesthetist in a wheelchair. And actually, what happened was one of my hospital staff's relatives. She was one of my hospital staff's relative, and they just found out that in the hospital there is a new doctor, pain physician was there, who basically sees patient differently and diagnose pain in a different manner. And if you show to him, the rumor is that you don't have to go for surgery, he will make you better with oral medicine and injection. Okay, with this background, let us go to the case. So this lady was came to the operation theater in a wheelchair, and she had a complaint of low back pain with left leg pain for 2 years. The pain was gradual on onset, and it was continuous in nature. The numerical rating score was pretty high. It was 6 to 8, and it was deep aching in nature at the lower back and in the left buttock. And this pain was radiating to the thigh and calf. Especially burning, tingling pain was appreciated by the patient, which radiated from left buttock to the thigh as well as to the calf. And this pain was aggravating in sitting, while walking, standing, and as well as even in supine position, she was having pain. And if we asked what was the relieving factors, she said like there was no, she didn't know what are the relieving factor, but if she put some heat over the area, especially in left buttock, pain gradually subsided. And she was being seen by multiple doctors in the city, renowned hospitals, and they have bombarded her with lots of medicine. If you see the medical history, she was taking pregabalin, gabapentin, duloxetine, and muscle relaxant, tizanidine, along with non-steroidal anti-inflammatory drugs and proton pump inhibitors. So this was a regular medicine. Okay, so she was having NSAID as well as neuropathic medicine as well as muscle relaxant, and she was also having short course of oral steroid on and off within these 2 years period. And she was known hypertensive, and she was taking amlodipine 5 mg, and she was also hypothyroid, for which she was taking thyroxine 25 microgram per day. And there was no history of trauma or no history of inflammatory arthropathy in the family. Okay, so on examination, basically patient was in wheelchair. So with two or three assistant, we had to bring the patient or support the patient to the examination bed. And in inspection, what we found out was patient was in severe pain, patient was in agony. The leg which she was complaining was externally rotated, the left leg, and on palpation, the range of motion could not be assessed because of the pain. But when we examined the patient, she had a bilateral sacroiliac joint pain. Left was more painful than right. Left piriformis was also positive. Free burst test was positive. Fair and favor test both were positive. Sacral thrust test was also positive. And on straight leg rising test, left leg, she had a radiating pain up to the calf when the leg was elevated to about 60-degree angle. And on examination of motors, she had slight weakness of left L5 nerve root. The weakness was graded as 4 by 5, and sensory and reflexes were all normal during examination. So she had blood test. ESR was 5, CRP was 5.5, rheumatoid RA factor was less than 5, vitamin D was normal 39, vitamin B12 was also 256, and bone mineral density scan was done, and T score was minus 1.58, and it was in a osteopenic panic category. She had an X-ray done, lumbosacral spine X-ray. AP in AP X-ray, there was an old compression fracture of L3 vertebra. She also had a grade 1 spondylolisthesis, L3 over L4. She had a reduced disc height in L5S1 region, and the normal sacroiliac joints were normal in X-ray. And since she had a spondylolisthesis, flexion extension X-ray of lumbar sacral spine was already done, and so grade 1 stable listhesis was the finding by the radiologist. So this is the typical X-ray of that same patient. As you can see, the SI joints both are normal, and if you see the spine is slightly tilted to the right side, most probably it is because of the pain. Left side because of the pain, and you can see marked by the blue dot, there is a wedge compression fracture. The red dot shows there is a slight listhesis. A grade 1 listhesis was there, and in the last area where there is a yellow dot, you can see the disc height of L5S1 is severely reduced.
ಇದು ಹೇಳ್ಬೇಕಲ್ವಾ ಅಣ್ಣದಿರಿಗೆಲ್ಲ.
The right side of X-ray, this was flexion and extension X-ray. You can see the blue dots. Here you appreciate there is not much change in the listhesis of the spine, both in flexion and extension. Thus, she was labeled as stable grade 1 spondylolisthesis L3 over L5. And in MRI was also done. She had multiple MRI done. I have just quoted the latest MRI. In MRI of lumbosacral spine, there was degenerative lumbosacral spine, and she had a disc prolapse in two different regions. One is at the level of L4 by L5, and there was a global disc bulge with left paramedian disc protrusion, which was compressing the left L5 traversing nerve root at the same level. And she also had L5S1 disc protrusion, global disc bulge, leading to mild narrowing of central spinal canal and right foraminal, neural foraminal stenosis, as well as moderate narrowing of left neural foraminal. And mild anterior wedging of L3 vertebra was reported in MRI. So this is our MRI. So this is the sagittal section. As you can see in the sagittal section, the disc prolapse is at the level of L4, L5, L4, L5, and you can also appreciate the foraminal narrowing in the right side, both in L4, L5, as well as in right, as well as in left side. This is our axial view of the MRI, which you can show, which is pointed by blue dots here, and this is L4, L5 region where you can see a global disc bulge, but the nerve compression was not that significant. In L5S1 also, there was a global disc bulge, more in the left side, but not significant compression of the nerve. There is a slight narrowing of the foramen, neural foramen, but traversing nerve root were not compressed. And this is the zoomed picture of the same patient. Here you can see within the yellow circle, you can see a global disc bulge at the center, and with a foraminal stenosis, both right and left side. So this was our MRI. So with this MRI, you can think of various problems you might be having. So with this MRI and clinical presentation, we might think that it can be disc prolapse of L4, L5, and L5S1 with left L5S1 radiculopathy, because patient was having pain in the buttock, which was radiating down to the thigh and to the leg. And the other diagnosis can be L4, L5 spondylolisthesis with lateral foraminal stenosis, left L5 foraminal stenosis, which can also cause similar type of pain. Another differential diagnosis was SI joint arthropathy. Piriformis syndrome cannot be ruled out in this case. It could also be painful osteoporotic compression, waist compression fracture L3, but it is less likely because the radiating pain was from the buttock to the left leg, thigh, and calf. And another problem that could be in this patient was left L5S1 facet joint arthropathy. So this was the possible. This is the possible differential diagnosis in this patient with the clinical presentation and X-ray and MRI. And she was planned for surgery. The neurosurgeon and orthopedic surgeon, basically they they were giving her lots of anticonvulsant like pregabalin, gabapentin, and all the neuropathic medicine. And they diagnosed this condition as L4, L5, and L5S1 disc prolapse with radiculopathy, and they were planning to do surgery. And just the day before the surgery, she came to visit me for any differential diagnosis and possible alternative treatment to avoid surgery. Okay, so my diagnosis after examination was bilateral sacroiliac joint arthropathy with piriformis syndrome left side. And right at the same day, we did a fluoroscopic guided left SI joint intra-articular steroid injection. About 4 ml of drug was injected, and 1% which consisted of 1% lignocaine and 20 milligram of methylprednisolone. And at the same setting, we did piriformis trigger point injection. And right on the table, just within half an hour to within 1 hour, pre procedure numerical rating score was 8 by 10, and post procedure NRS was 3 by 10. So after the procedure, within 1 hour, patient basically walked home with very little assistant. And on the discharge, she was given aceclofenac, baclofen, and duloxetine. And the same procedure was repeated 1 year back. And she is after this, it is already 4 years, and she is having a very little pain or no pain at all. And basically this is the picture of the procedure. This is the tunnel view injection in the left lower side of the SI joint, AP view, and in the lateral view, you can see the needle in the SI joint. You can also shaped dye around the SI joint. And after the dye, we injected about 4 ml of the drug, including steroid. And this is the piriformis injection, trigger point injection of the same patient. As you can see, this is the needle, and this is the piriformis. When I did my fellowship and in the beginning of my career, I used to do the piriformis trigger point injection in the fluoroscopic guided way, and this was done in the floor. Nowadays, I do everything in ultrasound, but that was the time when we did everything these procedure under fluoroscopic guided. And you can see the dye which showed the piriformis extending from the SI joint to the greater tuberosity of the femur. Okay, so this is basically patient's review. And after 1 year, it was around 2010, and this was a patient, basically, he has given a good review in Facebook. He was saying that if you see this red box, yeah, he is saying that he has taken his mother to various different pain specialist doctor in a renowned hospital in the Kathmandu, but all of them were giving her surgery as a last resort, and they were diagnosing this problem as a PIVD, disc prolapse, and radiculopathy. But on my examination, I found that the problem was more in the SI joint and piriformis. And after a simple simple injection in SI joint and piriformis, patient started walking. And he has also mentioned that it has been totally 1 year has passed, and his mom is walking very nicely. And he had posted this video of his mom walking, enjoying with the grandchildren. Actually, this patient was in severe pain for last 2 years, and she was in wheelchair. And everybody everywhere there she went, she was diagnosed as PIVD. And surgical operative procedure was planned in this patient. So this was the patient after the procedure, enjoying life with the grandchildren. Okay. So basically, and see, this patient again came to me like on September 2022 with a different pain, that is shoulder pain for 4 days, for which myofascial pain syndrome, trapezius pain was diagnosed. And she's living very happily now without with very less pain. And so here, if you see, regarding the diagnosis, the point of favor in terms of SI joint and piriformis is basically, what I advise to everybody is stick to the basic and don't treat MRI or X-ray. Treat the patient. Sir always tells us to examine the patient. Clinical examination and history is the most important thing for the diagnosis. If you rely on X-ray and if you rely on MRI, then rather than history and examination, then the diagnosis may not be correct, and you will be landing up in problem, and so the patient will also land in trouble. So what I suspect in this in her case was, everybody was looking at the X-ray and MRI, and there was multiple problem in X-ray and MRI. But and doctors were basically treating the MRI and thinking that it was PIVD of L4, L5, and L5S1. They were all suggesting her for the surgery. Okay, nobody had thought of SI joint or piriformis pain that could radiate to the leg, and that could be also a potential problem in this patient. So I also stick to my basic while doing examination in this patient. So here the points in favor in this case was, in inspection you see the leg was externally rotated, painful. That commonly happens in piriformis syndrome, as we have already taken the class, and you have already demonstrated in the clinical plural in the last time also, a young guy with the piriformis syndrome having a externally rotated leg. In palpation, we could appreciate the positive point was there was tenderness in both SI joint as well as in piriformis. The Freeburg's test is positive. This Freeburg test has been is with us for almost like it's an old test, but it's still old is gold. It's still done in case of piriformis. We suspect piriformis syndrome. Here, both favor and fair test was positive. That means problem was more to the SI joint and piriformis rather than in the discs. Okay. And the pain which was radiating from the buttock to the leg was basically, it was a referred pain from SI joint, as well as sometimes in case of piriformis syndrome, because of the sciatic nerve is just below the piriformis, they can have a sciatica like pain, which can be radiating from the buttocks to the posterior aspect of the thigh to the calf. Okay. So these were the points in favor for the diagnosis of SI joint and piriformis. And the point which was against the diagnosis was basically her straight leg rise test was positive at 60 degree. But you always remember that normally the range of SLR test is 30 degree to 70 degree. Sometimes in case of sciatica also, when we elevate the leg, there can be a pain which can radiate, and that whether the pain is dermatomal pattern or non-dermatomal pattern. Here the pain was along the sciatic nerve, and it was not in a specific dermatomal pattern. Okay. If the patient has had L5 radiculopathy, then typically patient will have pain on the lateral aspect of the thigh and leg, which can radiate up to the great toe. So that typical radiation was not then. But basically what we were doing mistake was, we were were basically misdiagnosing this radiating pain, referred pain for a radicular pain, and that was one of the most common mistake that was done in that patient. And the points that was against the diagnosis was also motor weakness. There was all about L5. If you the motor examination, the power was 4 by 5. That can also commonly happen if there is any sciatic nerve compressed with the irritation of piriformis. And another like points that was against the diagnosis was MRI finding indicating left L5 nerve impingement. So if you go for MRI and rely on MRI for diagnosis, and these cases can be missed. And since then I have found lots of patients with like SI joint and piriformis syndrome being mistakenly diagnosed as like disc prolapse and going for lumbar surgery or epidural steroid. So this thing has to be kept in mind. Okay, so low back pain which can radiate to thigh, buttock, or down to the leg are not always PIVD or disc prolapse. It can be simple SI joint arthropathy, it either degenerative arthropathy or inflammatory arthropathy, or sometimes piriformis syndrome can also mimic the similar condition. So if this patient was operated, then the problem will not be would not have been solved. Okay, same similar problem would have been there in the.
So finally, this patient was going to land up with a failed back surgery syndrome. Okay, series, before going to the case 2 discussion, because these all are different kinds of case. So
Yes.
let us complete the first case, and then we can go ahead with the second case.
Yes.
So what we learned from this case is what is the if we are making our diagnosis based on the image, we will be landing up with wrong diagnosis. Here you see we had so many problems in the image. There was compression fracture, which can have this kind of problem in the back pain, and some radiation might be there. It can be because of the listhesis that can cause the foraminal compressions, which can go radiate down to the leg. It can be because of the prolapse disc. There was in the MRI, there are several bulging discs. So what was very important, what series has done, emphasized, sticked to the basic, that means history and clinical examinations. So series has very nicely demonstrated why he thought it as a SI joint and piriformis. Another thing, remember, SI joint and piriformis syndrome can be coexisting together in many cases. What is the reason? Reason is the piriformis muscle is in close proximation or getting associated with the SI joint capsule. So when we are when there is a inflammation of the SI joints, then what can happen, there might be irritation of the piriformis syndrome, piriformis muscle producing to the piriformis syndrome, and that can in turn compress the sciatic nerve, and mild motor weakness and sensory loss is not uncommon along some of the fibers of the sciatic nerves, like here it was L5. So it was an excellent diagnosis, and the key here what to learn from this case is that we should be sticking to our basics. We should be giving more emphasis on the clinical findings rather than the image findings. And in any confusion, we should go ahead with the diagnostic block and can decide later. But what is most important part, never ever treat any patient based on the image findings. So any questions regarding this very nice, beautiful case?
Sir,
Yes.
I wanted to know, should we also examine hip in this condition? Hip examination to be done?
Hip also. In one day, I don't know in this batch or not, I told that the piriformis and the hip sometimes may be mimicking, because the hip also can cause the the internal and external rotation, which can be there in the piriformis. External rotation will be the internal rotation might be painful, so that can be mimicking it. And another thing is that the sacroiliac joint pathology and hip pathology might be common in the spondyloarthritis. So definitely hip should also be examined. I'm sure Series has examined the hip and ultimately came to the conclusion about the piriformis and the SI joint.
Sir, I had done a favor test, and favor test was done. It was positive, and as we know that favor test can be positive both in SI joint and hip joint, and sacral
But one thing to differentiate, suppose there's a patient is complaining of pain. Why patient is complaining of pain during the Favre test? If the patient is complaining pain anteriorly, then it is always because of the hip pathology. If the patient is complaining of pain during the Favre test posteriorly, then it is more commonly because of the sacroiliac joint, but sometimes it can be hip joint as well. So you have to remember that things also. Yes, it is.
and sacral thrust test was also positive. Though in X-ray there was no signs of osteoarthritic in both in hip as well as in SI joint, but tenderness was there as well as both favor was
Yes,
positive.
your procedure gave excellent pain relief immediately, which can be taken as a diagnostic block also. That means when you have injected in the SI joint and the piriformis, patient's symptoms was immediately relieved, which is an fair indication that the pain generators was the SI joint and the piriformis. But what you told, that is right. That means hip joint also should be taken into the differential diagnosis in these kind of cases.
So why I had a doubt is that in a patient who is so sick, doing the hip maneuvers like a- active abduction and adduction, would it have been possible if we had done the examination in patients who are in severe pain? Would it be possible to do and divert us from SI to hip? That was my
I told you one thing, that if on the clinical examinations, it is true when the patient is having severe pain, sometimes any of the clinical examinations is difficult, but we have to do it very gently. And if we are still having doubt, you give some analgesics and you examine the patients on the next 1 or 2 days. This is also a trick. Or otherwise, if you are still having some doubt, you can go ahead with the diagnostic block one by one and you can confirm your pain generator. These are the ways if you still have the confusions.
So if you see here, if you see, like he has mentioned that our mother was almost bedridden for almost 2 years with the same problem, and she needed assistant for everything. But after the procedure, you can see her walking very nicely, and that was one of the motivating factor for the pain physician are like these patients, where you can see the immediate pain relief, and it can motivate you to further push your pain carrier much more like
That is
aggressive.
true. That is true. That is true. Any other questions from anybody?
Sir, I had a clarification. Just
Hmm.
so whatever the SI joint pain she had was purely degenerative.
I think,
Uh,
yeah.
yes, it is. Yes, it
Yes,
is.
I think degenerative because the rheumatological profile was done and everything was normal.
Yes,
And
yes, exactly. That's what I wanted to ask. Sir.
yeah,
So it was not a part of any inflammatory arthropathy, spondyloarthropathy?
no, no, no. Everything was done
And
before the.
another thing is, if it was a spondyloarthritis, one single injection is not going to keep him fine for 1 year. Then the patient's pain was supposed to recur within 1 or 2 months. That was for sure. The patient was having a long-term pain relief. Why? Is it because of the action of the steroid lasted for 1 year? Answer is no. It is because of the breakage of the pain cycle. This can happen. SI joint pain, we can divide grossly into two broad type. One is your inflammatory, another is your mechanical. Mechanical means it is related to the stress. And in that mechanical, the most common thing is your degenerative. The degenerative things can be sometimes seen clearly on the images, but sometimes the degenerative changes are so subtle that it is not seen under the images. So, gold standard to make a diagnosis of the SI joint pain is not the image. Gold standard of making a diagnosis of the SI joint pain is to give local anesthetic and see what is the reference. And that is how we should make a diagnosis of the SI joint pain. Okay. But
Yes, sir.
spondyloarthropathy is definitely a possibility. That is one of the common cause. But if in this case spondyloarthropathy was there, then one single sort of steroid would not have given the relief for so long period.
Yes, sir.
And if you can see the SI joint here also, like it's a 68 years old female, it seems quite normal. I have just pushed
Right, right, right.
both SI joints are quite normal.
SI joint and hip joints are also looking normal.
Exactly, sir. For her, I mean, for the degree of pain that she had, the X-ray of SI joint, it's not, I mean, matching, I think.
Yes, yes.
Yes, and it is not matching in almost nearly 50% situation. That means SI joint pain and changes in the image in the SI joints matches only in 50% situation. In rest 50% situation, either there are changes in the images but no pain, and vice versa. Means there is pain but no changes in the image, like in this case.
Yes, sir.
Can piriformis syndrome be secondary to disc prolapse?
Yes, I already told you the piriformis syndrome can be secondary to the SI joint pain, or piriformis syndrome can be secondary to the disc prolapse as well. Because piriformis syndrome is ultimately a myofascial pain, and myofascial pain can be secondary to the other pathologies, including disc prolapse. In fact, we are conducting a study in our hospital. The study was taken the institutional ethical committee permission also, but unfortunately it was stopped in between because it was done by Akanksha, and Akanksha, when he left, the datas are there still. I'll be asking our current fellows to complete the study. So this was a good study where we have taken the piriformis syndrome, which is secondary to the prolapse disc. Secondary to the SI joint is a well-known phenomenon that in piriformis secondary to the piriformis. So piriformis syndrome secondary to the prolapse disc is not a well-known phenomenon, and that is the reason why we need some studies. And in the study, which is not published, so I can tell you the data where a quite significant number of the piriformis syndrome is there secondary to the prolapse disc, particularly the L5S1 disc. That is a possibility. But here in this patient, series clearly got the tenderness over the SI joint. Harvard test was positive. So here, the more likely that SI joint was the painful, and he has done the SI joint injection, which has given a good result. If the patient was secondary to the prolapse disc, then this patient would not have enjoyed so long pain relief if it was secondary to the prolapse disc.
Sir, what I found out,
Thank you, sir.
what I found out is sometimes I also do mistake with like PIVD with L5S1. It was there in MRI, and on examination, piriformis is very tender. So as we know, piriformis gets nerve supply from L5, S1, as well as S1 and S2. Okay, so ventral rami from S1, even from S2, or even from L5, the nerve supply is there with piriformis. But in these cases, when I thought it was piriformis and I gave a trigger point injection in the piriformis or even a local anesthesia, pain relief was there only for 2-3 hours, and again pain started. So if it is secondary to disc prolapse, then pain usually starts like after for like few hours or few days. It will not be long-term pain relief as sir has said. But if it's purely piriformis syndrome secondary to SI or purely muscle contraction only, then the trigger point injection will have an excellent result and it will have a long-term result. That's how I, in the beginning of my career, I used to give few piriformis injection in PIVD where there was the radicular pain was only up to the buttock or thigh. So I was very confident this is piriformis syndrome. But after injecting, after 1 or 2 hours of injection pain-free period, the patient used to have again pain, and that's when I
Because that was because it was secondary to the other pathologies, other secondary to the prolapse disc.
So in these cases, I usually tell them it is basically due to the disc prolapse, not the piriformis syndrome. So that was my experience.
Any other questions from anybody? Otherwise, series can go with the second case. Yes, yes, yes.
Sir, I had a previously I had a patient with SI joint pain only. Classical it was. So we did a SI joint injection. She was good till 1 month. There was a pain-free period. After 1 month, she again started to have light pain itself. By the end of 2 months, she had the same pain as that of before. So what
This is
can
not
I
this is not uncommon. This can happen both in the inflammatory as well as the degenerative conditions. Because if sometimes the breaking the pain cycle give you a long-term pain relief, but sometimes it might be giving only the 4 to 6 weeks or 4 to 8 weeks of pain relief. What happened in your case? So if the patient, you are ruling out the inflammatory sacroiliitis, then you have to take it as a degenerative sacroiliitis, and these are the patients where radiofrequency ablation of the lateral branches of the sacral nerve roots or the cryoablation of the lateral branches of the sacral nerve roots are indicated. So these are the conditions where there is initial good relief of the after the SI joint injection, but the pain is coming back, and you have ruled out all the other inflammatory markers or other ways, Amor criteria, to rule out the ankylosing spondylitis or sacroiliitis. Then you have to think for the long-term relief with either
Yes, sir. The
RF,
inflammatory
either
first
RF
thing
or
was
cryo.
done. The second time when she came after 2 months with the pain, I had asked for a MRI if anything else has been missed, Chanta. In that, the second time, the MRI showed mild sacroiliitis. It was written.
So
So should I?
then you have to think for the ankylosing spondylitis or spondyloarthritis. If the Amor score is, you probably know what is Amor score.
Yes, sir. In
Yes, Amor
spondyloarthritis.
score is a clinical criteria because making a diagnosis of the spondyloarthritis is difficult. Only single criteria, HLA-B27, sacroiliitis, is not enough to make a diagnosis of the spondyloarthritis. So to make a diagnosis of spondyloarthritis, it is a composite clinical and image score. So there are several criteria, starting from the alternating buttock pain, then the history of your
Right.
psoriasis, or a lot of different criteria are there. Heel pain, ankle pain, the HLA-B27, sacroiliitis. So you have to, it should have a composite score. And finally, if the score is 6 or more than 5, then your diagnosis is confirmed. So you should be looking at if the patient is having the sacroiliitis, even if it is a mild sacroiliitis, it carries a score of 3. So if the patient is having the buttock pain, alternating buttock pain, heel pain, then you have to make a score. If it is 6 or more, then you should start the disease modifying drug, particularly the tofacitinib should be the drug of choice in these situations. Okay.
Yes, sir.
So
Yes, sir.
sacroiliitis is one of the very important diagnostic criteria, though alone sacroiliitis is not enough. Sometimes we get the isolated sacroiliitis without having the spondyloarthritis full-blown features. So in those
Yes, sir.
situations, you
She
need not
had
start.
left side sacroiliitis, not the right side, only left side,
It
and
can be
no other.
unilateral. It can be unilateral, but the other criteria should be matched to see it. If it is not, then only sacroiliitis if it is there. If the Amor criteria is less than 6, then you should go for with the radiofrequency or cryoablation. If the Amor criteria is 6 or more, then you should not go for any further interventions. In that situation, you should go ahead with the tofacitinib or the biologics. Okay.
Okay, sir. Thank you, sir.
What cryo? So what cryoablation you're talking about, sir?
Cryoablation is, you know, the radiofrequency ablation.
No, sir. I was asking cryoablation of which nerve?
Same, radiofrequency ablation and cryoablation targets are same. It is the lateral branches of the sacral S1, 2, 3. These are the 3 main target. Apart from that, sometimes we also ablate the medial branch of the L5 and the S4. But the main target for both radiofrequency and the cryoablation is lateral branches of the S1, 2, 3. Okay, it is the same target. You can ablate it with a heat in radiofrequency, or you can ablate it with a cold with a cryo.
Lateral branches are same as we do the transforamen, like S1 injection.
No.
Foraminal injection.
No. These are different. These are different. The sacroiliac joint, lateral branches. Okay. Probably there is some videos, or I made it, but I don't remember whether I posted it or not. So I'll be recently we have done one case of lateral branches. Lateral branches is just lateral to the sacral foraminus. It is not same as the sacroiliac joint injections, or it is not same as the S1 root block. So I'll be posting that. Who is this talking?
Yes, sir. Dr. Suman, sir.
Suman. Okay, so this video will be for you by the next class. So I'll be
Okay.
posting it and I'll be sending a link to you. Okay, so how to do the lateral branch ablation with the radiofrequency. This was the radiofrequency case, but the same
Yes, sir.
technique is for the cryoablation as well. So I'll be posting it to you and I'll be sending link to this.
Okay, sir. Thank you so much.
Okay.
Sir, in this case, the piriformis trigger point injection we need to give into the muscle, sir.
Right, into the muscle. But nowadays, another very important thing we are learning, that you can go ahead, but this is possible when you are doing it with the uh, ultrasound. We can go ahead in front of the piriformis muscle, because in front of the piriformis muscle, we are having the sciatic nerve. And you can do a little bit of hydrodissection of the sciatic nerve with 5% dextrose. That will be giving an excellent long-term benefit also. So nowadays, we do these things. What series told, this was an old case. That time we mostly used to do the serum, but nowadays with the ultrasound, we also add the hydrodissection of the piriformis muscle. Apart from giving the local anesthetic within the piriformis muscle, we go a little bit ahead in front of the piriformis muscle where the sciatic nerve is there, and we do the hydrodissection. Again, we are having the videos in the YouTube channel, so you can go and search it in the YouTube channel how to do it under the ultrasound guidance, how to do the piriformis injection as well as the hydrodissection of the sciatic nerve.
Okay, sir. Thank you.
Okay, series, you can go ahead
Sir,
with the next case.
Yeah.
Okay, more
sir,
questions?
one question, sir.
Yes, yes.
Sir, a few days back, sir, I examined a patient. She was having L4, L5 disc prolapse, and she had a radiating pain to the left side. It was radiating uh, till feet and till big toe. And along with, sir, this Faber on Fair test, this she was having tenderness on hip area, hip joint. So is it like linked? Is it possible, sir, to have?
Yes, you know, if the posterior hip, the tenderness is there, it can be hip, it can be SI, it can be piriformis, or it can be prolapsed disc along with the secondary myofascial spasm. So these all 4-5 possibilities are there when the patient is having the buttock pain, which is radiating towards your toes. So you have to do all the clinical tests, and if you are having the confusion, you can go ahead with the diagnostic block. Your MRI will be helping you to make a diagnosis. So it is a composite diagnosis. Diagnosis cannot be made on a single yes or no. Okay.
Yes,
So in
sir.
your case, you have
Yes,
to
sir.
remember all those possibilities. All these possibilities are there. Okay, series.
Okay.
Go ahead with the second case.
Okay. So second case is not that much interesting as first case, but here the main goal of my this presentation of second case is that most of the time we diagnose the back pain as a mechanical back pain. We basically say that everything is, we don't try to identify the pain generators in the back. So what happens is lots of patient like visit doctors, multiple doctors, and they diagnose, especially our orthopedicians and our friends usually diagnose them as a basically as a mechanical back pain. They usually do not try to find out the pain generator, and normally the treatment might be the same initially, and later on, if it's more narrowed down, the treatment can be specified if we try to find out the pain generators. And this can be a very the patient will be also knowing the exact pain generator. He will also be psychologically pain free or stress free if he knows what is the main pain generator that is giving him a back pain. We just say any back pain, like mechanical back pain, then patient can have can be worried or anxious, or what is the problem, why I'm not getting better. So this kind of problem can happen. So I'm basically presenting a young guy, a retired army, who was posted in eastern part of the Nepal. We came to the pain clinic with low back pain for 1 year. And if you see the history of the pain, it was sudden in onset. It was left sided, and it was deep aching in nature, non-radiating, and numerical rating score was 3/6. That means it was not that severe so that he has to take medicine for a long period of time. It was a bearable pain, and it was aggravated whenever he changed the posture during supine position. And pain relief was there with non-steroidal anti-inflammatory drug and heat. There was no history of trauma. There was no history of inflammatory arthropathy in his family or in him, and there was no history of morning stiffness. And so he had gone with this problem for multiple hospitals, and all the doctors were leveling him as a mechanical back pain, and they used to give him a short course of non-steroidal anti-inflammatory drug, physiotherapy and heat, and that used to decrease the problem for a short period of time. But again the problem reoccurred in every 2 or 3 months, and with this problem he used to go to various hospitals, and in all the hospital the diagnosis was mechanical back pain. Okay, so when on examination, if we examine the range of motion, there was extension, and extension loading was positive. He could localize the area of pain with his finger, and on examination there was tenderness in left lower paramedian area L5S1. Favor, fear and SLR test were negative. Motor, sensory and reflex all were normal, and his lab investigation was, he had the a few lab investigation with him that he had brought with him. So it was uric acid was checked in, it was 6, creatinine was 1, bilirubin was 1.4, which was slightly high, triglycerides was bit high, and he had one x-ray. So he had lots of x-ray, but because of frustration everywhere he used to go, doctors used to prescribe x-ray of lumbosacral spine, and they used to see the x-ray and say that everything is normal and nothing to worry. Because he was in army, and retired army, mainly maybe because of the excessive work he was doing in when he was recruited in army, and that's why he was having a pain. And in the x-ray basically there was sacralization of lumbar vertebra, and investigation that I ordered in the first visit was CBC, AS, and CRP, which was not done in the patient. But he had done all these tests, but it was not brought to the in the pain clinic at that time. Okay, so this was the X-ray. That he had brought. So here you can see the this is D12, L1, L2, L3, L4, L5 is there. So SI joint seems normal. Here you can see lumbarization of the sacral vertebra. Here you can see the fifth lumbar vertebra is being fused with the sacral ala. Sacrum. So this was his typical X-ray. Actually, I asked for other X-ray also, but he was from far eastern part of the Nepal, and he had brought only this X-ray. So basically with this, so and the diagnosis of mechanical back pain was given to him, and I'm sure everybody, like most of the clinician, usually level this pain as a mechanical back pain. And if you think there is not much uh, problem in the x-ray, SI joint seems normal, the vertebra seems normal, though the lateral view I couldn't get the lateral view because he had not brought this one. But here you can see there was a fusion of the L5 vertebra with the sacral ala, and this was not mentioned to him in any of the previous hospital or the clinic. Even the radiologist had leveled this X-ray as a normal X-ray of the lumbosacral spine. So the patient was very much anxious. X-ray is normal, everything is normal, but I'm having recurrent back pain, especially at night when I change the position. Though it was not that much severe, but there was some nagging pain. And as we all know, if there is pain for a long period of time, for about like more than 3 months, then that pain will not only hurt us physically, it will hurt us mentally also. So he was mentally very disturbed, like everything where he goes, all the diagnoses were normal, but he was having recurrent pain, but it used to subside with non-steroidal anti-inflammatory drug and heat. And diagnosis, this X-ray was also diagnosed as normal X-ray in all the hospital that he had visited. So like normally these few diagnoses will come in our mind when there is any mechanical back pain. So we can think of that can be a facet joint arthropathy because he was having pain in the left lower paramedian region in L5S1. And on examination you could also see that extension and extension loading test was positive. He could point at the site of pain that was in left sided, just lateral to the just medial to the SI joint, left sided SI joint. Another diagnosis could be a sacroiliac joint dysfunction in this patient, because pain area was very much close to the SI joint. Though favor test was negative and tenderness was not there in SI joint, sacroiliac joint dysfunction can also be there. Myofascial pain syndrome could also be the diagnosis in this patient, because pain was decreasing with non-steroidal anti-inflammatory drug, and with heat, and with some kind of physiotherapy, stretching exercise. Spondyloarthropathy cannot also be ruled out in this patient, because only one uric acid test was done. ES and, and CRP was not ever done in this patient, but history doesn't history was he was not giving typical history of spondyloarthropathy. There was no morning stiffness, there was no in spondyloarthropathy usually there will be a family history of inflammatory arthropathy. SI in X-ray, there can be SI joint sacroiliitis was not there. Uh, Typical morning stiffness was not there. So this spondyloarthropathy could be there, but it may not be there. So discogenic back pain can also be there, because like he was and the age also favors the discogenic back pain, like 46 years young male, retired army. That could They can easily have discogenic back pain. But the point against the discogenic back pain was he could point at the site of pain. In discogenic pain, back pain, usually pain will be vague pain will be around the lower back, and the patient will not be able to identify or point out where the pain is. So Bartoliti syndrome can also be the can also be the differential diagnosis. Actually, my diagnosis was Bartoliti syndrome, because as you know, but I'm sure you will be also studying Bartoliti syndrome. So in this case, my diagnosis was Bartoliti syndrome giving pain, and disc herniation can also be one of the differential diagnoses in this patient. So my diagnosis in this patient was Bartoliti syndrome. So it was not mechanical back pain. So it is a the diagnosis was right there in the X-ray, but nobody had told him, or the radiologist, I don't know, for some reason they don't basically diagnose the Bertolini syndrome or lumbarization or sacralization of the for the spine. So basically, as we know, so if you see the X-ray of the patient, you could appreciate that L5, like it was type 2B Bertolini syndrome was there, where the transverse process of the L5 lumbar vertebra had made like joint connection with the sacrum. So it can be a joint, or it can be fused also, depending upon type of the transverse process and how the transverse process is getting attached to the sacrum. There are five different type of Bertolini syndrome. Basically, it is a congenital disorder where the patient can have a back pain, but initially patient will not have back pain. So later on their life, about in late 20s or late 30s or after late 40s, they will start having back pain, which usually resolves with like NSAID and heat. Sometimes there can be radicular pain, if it gives more pressure to SI joint, or there can be associated disc problem along with Bartolini syndrome. So it can be associated with like SI joint problem, or discs, or even facet. But the main problem that the patient was having was like symptomatic Bartolini syndrome. Okay, so here basically there is a lumbosacral transitional vertebra, which commonly articulates with the sacrum. Okay, so and there are various type of Bartolini syndrome. So the common symptom in Bartolini syndrome, patient usually have they might be asymptomatic for about late up to late 20s or late 40s, and symptom can happen after his 20s or 40s, and there can be unexplained pain in the groin, hip, or lower back, or sacroiliac joint in case of Bartolini syndrome. And there can also be sometimes sciatic nerve pain, which may radiate to the buttock or lower back to the leg. And there can also be stiffness and mobility issue, but the stiffness, if there is present, will be less than 30 minutes. And there can also be unilateral muscle spasm because of the uneven distribution of the weight, because of the transitional lumbosacral vertebra, and this myofascial pain can also be one of the secondary cause of low back pain due to Bartolini syndrome. So this is basically this was the X-ray of the patient, And as you could see, if this is the T12 reef, okay, this is the D12 vertebra, and if you count, there is L1, L2, L3, L4 there. L5, if you see it, the both of the transverse process of L5 was made a pseudo articulation with the sacrum. So this is type 2B Bartolini syndrome. So this was causing left-sided Bartolini syndrome was causing pain. And if you see this Bartolini, the pseudo joint of Bartolini is very much close to the SI joint or with the L5S1 facet joint. So the facet joint or SI joint misdiagnosis can be very much common in these kind of people. We might misdiagnose this case as a SI joint problem or purely facet joint problem, but here, because this pseudo articulation is very much near to the SI joint and the facet joint, we can commonly misdiagnose this as a SI joint arthropathy or facet joint arthropathy. And if you see, this is here, there is complete articulation with the pseudo joint articulation both side, and here you can see also narrowing of the L5S1 foramen. So here, because of too much narrowing of the L5S1 foramen, the patient can also have a radicular pain going to the legs and beyond. So he can also have typical L5 radicular pain later on his life because of the narrowing of the foramen, L5S1 foramen. Patient can also have later on SI joint problem because of the unequal distribution of the weight. But for now, in this patient, the diagnosis was Bartolini syndrome, and this is the CT scan image of the same of the different patient. I just wanted to show you that this is will be the normal in CT scan. If we do 3D reconstruction of the CT scan, we can easily see the how it is being articulated, or if there is any fusion of the bone also we can easily see. So here there is, you can see there is a pseudo articulation formed by this transverse process with the sacrum. This can be a common source of pain in a patient. So if these kind of patient comes, we should not blanketly label them as a mechanical back pain. We have to try to find out what is the we have to pinpoint the pain generator, and once we pinpoint the pain generator, then the treatment plan will be easier, and patient will also be knowing what is the condition, what is giving him a problem, whether that problem will be resolved with the temporary measures, or they can have a permanent treatment for these measures. Okay, so this is the case of Bartolini syndrome. So this is the basically prescription of the patient, and here you could see the type 2B I had labeled, and I have given him some non-steroidal anti-inflammatory drug for few days because of the back pain that he was having, and I also gave him like duloxetine. And here duloxetine in these conditions can provide a long-term pain relief, because you know it's a chronic pain. This duloxetine is a FDA approved drug for a chronic low back pain. So for those patients who require non-steroidal anti-inflammatory drug for a long period of time, these non-steroidal anti-inflammatory drug like diclofenac or ibuprofen, this can cause like problem in the kidneys or in the stomach. So in these conditions, that duloxetine can be an excellent painkiller. Okay, so here I have prescribed the duloxetine, and I've also I've told the patient if he can do it to do a CT scan and to be sure, because no because the radiologists were also saying that it was a normal X-ray, and all the doctors who had seen the patient was saying that it is a normal X-ray in spine. And so I had advised him to go for the CT scan of the LI lumbosacral spine for 3D reconstruction. I had also given a blood test ES and CRP, because it was not done in that patient, because patient was young, he was having low back pain, on and off low back pain, and pain was subsiding with non-steroidal anti-inflammatory drug and heat. So in these case, it is always advised to go for better to go for ES and CRP as a screening test to rule out any inflammatory arthropathy. And our future plan, as suggested in this red box, is if we can go for the steroid injection in the pseudo articulation joint formed by the for the Bartolini syndrome, or we can go for radio frequency ablation. So this future plan will be much more precise if we can level the, or if we can pinpoint the problem that the patient is having. So this is the second case of Bartholin syndrome. I'm sure everybody will be seeing these cases, and unfortunately I don't know why the radiologist usually does not diagnose this Bartholin syndrome, and it is our duty to diagnose and make patient understand that this is the congenital problem, and this is not just a mechanical back pain, and treatment modalities are available if required, and you always go with oral non intervention management with oral pharmacotherapy, along with physiotherapy. And if it's not relieving, then once we pinpoint the pain generator, we can always go for the specific treatment, that is radiofrequency ablation or steroid injection in the pseudo joint. Thank you, sir. So this was the second case, sir. Hello. Yeah.
Yes,
Am
it
I,
is. Yes. So
this was just for a mechanical back pain. I wanted to tell the student that we have
yes,
to.
basically, mechanical back pain itself is a vague term. Only mechanical back pain carries no meaning. Mechanical back pain also, you have to tell us where is the pain generator. It can be sacroiliac joint, mechanical sacroiliac joint pain. It can be facet joint. It can be myofascial. It can be disc. It can be Bartholin, like what you have shown there. So it is not a specific. It is a very non-specific term. It is a broad term. Mechanical back pain means where there is absence of any inflammatory pathologies, we call it as a mechanical. This is the, if somebody is asking what is mechanical back pain, mechanical back pain term should be always be avoided because it is such a non-specific term. Still it is being used and it carries the meaning that it is not a inflammatory pathology. So it do not make a definitive diagnosis. So here the diagnosis was Bartholin syndrome. Bartholin syndrome is not a, though it's not uncommon, but still it remains misdiagnosed, or it remains wrongly diagnosed with something else. And here what we have done is a right one. So like a pain physicians, we should be always remembering that whenever we are having anything suspecting, we can go ahead with the diagnostic block, local anesthetic injection, and we can confirm the diagnosis or rule out the diagnosis. And here, this case, normally it is a transitional vertebra. It is between the sacroiliac joint below and the L5S1 facet joint is above. So it is a broadened transverse process which is forming a pseudo joint with the ala of the sacrum. So here the patients normally shares the common clinical features of both facet joint as well as the SI joint. So some features of the SI joint will be there, some features of the facet joint will be there, and diagnosis is really difficult unless it is here in your mind. And you have to make a diagnosis like what the series did, and the long-term treatment is the ablation of the nerve supplying it. So any questions from the audience, from the participants?
Sir, any spontaneous fusion is possible, sir?
Pardon?
Or spontaneous fusion of this
No, spontaneous fusion is
facet?
not possible. Spontaneous fusion is not possible. But if the pain is not the relief by all other different ways, then one of the treatment option is your fixing the transitional vertebra. You can fix it with the sacrum so that it becomes a part of the sacrum. Fully sacralized L5 vertebra do not cause pain. It is the partially fused one, incomplete fusion, causes a pseudo joint, causes friction, and that causes pain. So in the natural course of the disease, normally it is not get fused itself. So if you wish to avoid the surgical procedure, then the local anesthetic steroid injections, or the radiofrequency procedures, these are the choice to take care of this patient's pain.
Okay, sir. Thank you, sir.
So
Yes,
where
what
is the steroid injection given in these cases?
Around the pseudo joint, in and around the pseudo joint.
But there is no space in the joint.
There
Yes.
is, you can see the X-ray. You can see the space in the joint. Look, if you see nicely, you can see the space in the joint. Can you see in the marker? Here also you can see the space in the joint. Here also you can see the space in the joint. In both sides, where I have marked with yellow, you can see the
Yes.
not completely fused. You can easily see the joint marking here. Okay,
And you can
here,
place your needle into that space.
here also in the CT scan also you can see the joint line in both sides. So these are the pseudo joints. where you have to give steroids.
Okay. Okay, sir.
And it can also mimic radicular pains. Look at the foraminal here. The foramen is big, L5S1 here is small. Sometimes the foraminal stenosis can give you a radicular pain. L5S1 radicular pain symptoms can also be given in this kind of patient. But the
So in
CT
such patients with radicular pain,
yeah.
in such patients with radicular pain with a very narrow foramen, what is the solution in such cases?
So always try to relieve pain with transforaminal. If not, we can do foraminoplasty. We can widen the foramen endoscopically. We can widen the foraminoplasty. First is transforaminal epidural, selective L5. If it's not giving the long-term benefit, then we can go for the endoscopic foraminoplasty. Increase the size of the foramen.
Thank you.
Sir, what is this extension and extension loading test? Sir, positive.
So as sir has also told, like because extension and extension loading test is the it's one of the basic tests to see whether the facets are involved or not. Patient is asked to extend back and load the SI joint. Okay, load the facet joint. If it is positive, then we basically might think that the pain generator can be a facet joint here, because the facet joint is very much close to the Bertolini. Like the L5S1 is very much facet joint is very much close to the Bertolini, this pseudo joint. So here in this patient, the extension and extension loading these joint can was causing problem rather than the facet joint, because there was rubbing of the joint when the patient was doing a extension, like the facet joint being loaded. Here, most probably the pseudo joint, the transverse process which is attached to the ala, sacral ala, was being rubbed when the patient was doing extension or extension loading. Actually, this was his main problem. When he changed his position at night, he could feel pain in the lower back. That was only his problem. On examination, we could see extension and extension loading positive, but his only pain was pain in the lower back at night when he changed his position from right to left side. This is also very much common problem complaint in case of facet joint arthropathy, L5S1, L4, L5. They will have pain during change of position from supine to lateral or lateral to supine. They will have back pain. So in this patient also, that was only complaint with him, with which he came to the pain clinic.
So a patient coming if we are giving, that is only 15 days history. He is not having any relief with the painkillers, NSAIDs. Can we go with interventions, sir, like transforaminal epidural injections, if it is very short pain? In acute stage.
If the pain generator is like neuropathic, but like you have to understand whether
if the patient is not having the radiating pain, then the injection into the joint, pseudo joint, is the choice. If the patient is having the radiating pain because of the narrow foramen, then only, or some neurodeficit is there, then only transforaminal. Otherwise, transforaminal is not the first choice here in this Bartolini syndrome.
Okay. Sorry, sir. In this, it is not in this context, sir. Actually, a patient came with 15 days history where L5S1 disc prolapse was there. So within 15 days, can we go for intervention? You told no, sir. Like
yes, you can. If your conservative management with the medications is not giving any relief, and if there is no red flags like major motor weakness, your progressive sensory weakness, and the bladder valve dysfunction, if it is not there, then you can go ahead. If the conservative management has failed, definitely you can go ahead. And in fact, the early steroid injection gives a better result in the prolapse disc.
Okay, sir. Okay, that was my doubt, sir. Thank you.
Sir, good evening. Sir, I have a question, sir.
Yes.
Sir, in this particular case of this army personnel, sir, in case, how will we rule out that this pain was not facet joint pain at all, sir, since the extension and extension loading test
I
was
told no, this patient presents the symptoms of both SI and facet. So how to rule out? Already series has told it that giving the local anesthetic injection into the CUD joint, if the pain is relieved, that means you are confirming your pain generator. Okay. And if the pain is not relieved, then you can go ahead with the facet injection and see whether the facet is involved. So this is how you have to search and find it out where is the pain generator. Okay.
right, sir. Thank you, sir.
Okay. So can we go ahead with the third case?
Okay. So third case is very interesting. Actually, we see this kind of cases in a lot of time. Actually, like when I was preparing this topic, I told my IT department to see how many cases that we have seen of that case. And it was already within 2 years. The list was almost 104 cases was already seen of the cases that I will be presenting to you. Okay. So here I would like to first talk about the disease first and go to the cases instead of presenting the case and go back to the disease. So the disease which I'll be discussing is called fibromyalgia. Okay. So this fibromyalgia is a very like it's a chronic it's a neuropsychomuscular disorder. Basically it is characterized by pain and tenderness in the multiple side of the body. So patient will come with pain in the multiple side of body, in neck, back, upper back, lower back, leg, hand, and everywhere. And along with pain, they will also have symptoms like they will have fatigue, they will have sleep disorder, they will also have fibrofog. Basically, fibrofog means they will have different difficulty in concentrating, or they will have memory problem, loss of memory. Okay, and they will also have various somatic symptoms such as like anxiety, depression. From head to toe they will have problem like hair loss, dry eye, like tinnitus in the ear, jaw pain, or like gastritis or GI symptom, like sometimes diarrhea, sometimes like constipation. They will have dysmenorrhea, they will have frequent urination, they will have headache, they will have dizziness, sun sensitivity might be there, and they will also have typically like inflammatory arthropathy. They can have pain in the multiple joint with stiffness. So with all these vague symptoms, patient can come to you. So here the main motto of presenting this like case is since the patient will have multiple symptoms, we should be clear, we should be thinking of this diagnosis in our mind, that if the patient is having multiple side problem with various vague problem, other vague problems like from head to toe, like dry eye, hair loss, like gastritis and anxiety, depression, palpitation, uh, along with that they will have a severe fatigue, like sleep disorders will be there, and they will have also concentration difficult. So these things have to be carefully extracted in history. Okay. So normally what happens is when the patient with fibromyalgia comes, we don't give much time in the patient. We'll just ask where is your pain, and they will say like they have a pain in this side in the body, but we usually don't go in detail regarding what are the other symptoms that the pain patient is having. So what happens is we are pain physician, we usually concentrate only in pain. So where is pain? We'll ask. Is they will show that pain in the multiple site, but we do not ask the leading question. Like here, the leading question in this question will be like, do you have a fatigue or not? So do you have any sleep disorder, or are you having any multiple like concentration problem or memory problem, or what are the other problem like pain in the joint? Or so this the main aim of this class, the presentation is sometimes you have to go and ask other symptoms also, like symptoms, other symptoms which is not related to pain the patient is complaining. So if you do that, then the cases of fibromyalgia will not be missed. Otherwise, if you just ask history of pain and joint pain or muscle pain and come to the diagnosis, then a lot of time the diagnosis will be like misdiagnosed. So fibromyalgia can be misdiagnosed as rheumatoid arthritis or inflammatory arthropathy very much easily, because these patients will also have multiple joint pain, sometimes with stiffness. So any young patient, female patient or young patient who is coming with pain all over the body, especially in the joint and and if they gives history of joint stiffness also, we basically stop at this point. But the main thing is sometimes we have to extract other history too, such as like fatigue, sleep disorder, or anxiety, depression. These things we usually don't ask during our clinical evaluation. So I advise you to ask. Sometimes we have to go for other history apart from pain for the diagnosis. So like in this fibromyalgia case, here the patient will have vague symptoms which usually they don't tell in their first visit. You have to ask them, and if this diagnosis is in your mind, then only you will be able to ask these questions. Otherwise, if you don't know what is fibromyalgia and what are the other symptoms of fibromyalgia, you'll never ask regarding sleep disorder or fatigue or anxiety in the case. And if you don't ask this history, then easily the fibromyalgia case will be misdiagnosed or underdiagnosed. Okay. And this fibromyalgia is also known as silent enemy or unseen enemy, like coronavirus. We cannot see this the problem, but the patient usually complains of pain and other various somatic symptoms. And usually the cause is unknown, and usually they will have some trigger like stress or triggering factor, like financial stress can be a triggering factor, or emotional stress or physical stress that the patient might have had in a childhood. That can be a triggering factor. Nowadays the fibromyalgia problem is very much common in pain clinic because we have lots of stress in our workplace also. Okay, so in workplace also we have to complete certain tasks at given time, or we have to be more productive in the workplace also. So this continuous demand in the workplace has also increased the rise of fibromyalgia patient in day-to-day clinic practice. So in my data, within these two period, almost 104 patients with fibromyalgia had come to my clinic. Okay, and normally this, if you see the patient profile, usually they are female, and it is said that about 4% of the population, female population in the world, has fibromyalgia. And there can be genetic predisposition also, like mother, sister, or other family member in the in the patient. If they are suffering from fibromyalgia, then there can be genetic predisposition of the fibromyalgia as well. Okay, so here if this is the patient, they will complain of pain in multiple side of the body. Here they will complain of the neck pain, chest pain, pain in the hand. Not only pain, they can also complain of stiffness in the joints also, like in the knee. If you see in the back, they can complain pain in the neck region, on the or around the trapezius, or the lower back, or in the upper part of the thigh. So there are almost 18 to 19 tender points in case of fibromyalgia. And apart from this, the main thing is we should not stick only to the pain history. We should ask other history also. So these history can also be present in fibromyalgia. For example, chronic headache, dizziness, anxiety, depression, cognitive impairment, memory impairment can be there. Patient can have problem in the vision. Patient can have like muscle myofascial pain, or muscle pain all over the body. They can have twitches, or they can even you can have even pain symptoms which is very much similar to neuropathic pain. They can complain of tingling and burning sensation of the hand and leg, or even numbness of the hand and leg. These problems are very much common in fibromyalgia. And whenever we think of tingling sensation or burning sensation, we can jump into the conclusion of being like a lumbar disc prolapse or any peripheral neuropathy. Though these mm, diagnosis can come in our mind. So we have to know that in fibromyalgia also patient can complain not only of deep pain, they can also complain of burning pain with numbness, or tingling pain is very much commonly our common complaint of the patient in pain clinic. So apart from that, they can have a urinary problem, they can have like dysmenorrhea during menses, they can have morning joint pain with morning stiffness. So with morning stiffness, we can easily misdiagnose this as an inflammatory arthropathy. But having said that, fibromyalgia is also commonly associated with inflammatory arthropathy. Those patients with inflammatory arthropathy can develop fibromyalgia. So these are like cousins. They can or myofascial pain is also commonly associated with fibromyalgia. So two different entities can be of same in a same patient, or it can only be fibromyalgia. So any joint pain with morning stiffness, we should not rush into conclusion that it is a degenerative arthropathy or it is an inflammatory arthropathy. people with fibromyalgia very much commonly present with joint stiffness and joint pain. So nausea and vomiting are common. Chest pain is also very common. Skin complaint like sun sensitivity and itching of the skin are very much are a common problem. But the main problem, the patient will have a multiple joint pain, plus they will have fatigue. Fatigue is one of the most common problem in case of fibromyalgia. Another common problem is sleep disorder. Sleep disturbance are very much common in patient with fibromyalgia. Third one is memory impairment. So cognitive impairment or memory impairment are the key features that you should look while taking history of fibromyalgia. Okay, so in normally when the patient of fibromyalgia comes, so as I have told, it can be associated with inflammatory arthropathy, it can be associated with SLE, myofascial pain syndrome, irritable bowel syndrome, or depression and anxiety can also be associated with the fibromyalgia. So it can be either two different entity in the same person, or it can be a same it can be a part of fibromyalgia, and you can misdiagnose this fibromyalgia as a inflammatory arthropathy or myofascial pain syndrome, or even some people even diagnose this for as a depression or anxiety. And if you see the chart here, the patient will be having multiple problems. So these patients usually go to multiple doctors. Okay, they have a anxiety and depression there, so they will go to the psychiatrist for the treatment. So they have a muscle pain and joint pain, so they will go to the rheumatologist or orthopedician for the diagnosis. They will have a headache and like dizziness or vertigo, so in these cases they will go for the neurologist. So if you see the history of fibromyalgia, or they will have a dysmenorrhea or urine problem, so for these cases they will have they will go to the multiple doctor, and all the tests will be negative. Okay, all the tests, especially the complete blood picture, ESR, CRP, like vitamin B12 level, vitamin D level, thyroid function test, which we commonly do in patient with vague complaint. So all these tests will be negative. And we usually, this patient with fibromyalgia, it will be a family problem, so everybody is worried because of the pain and other vague symptoms. The patient usually visits to multiple doctors, but all the doctor will say that it is not, it is, you are normal and there is nothing in the test. And it is our normally what we commonly think, that whenever there is problem, it should be reflected in blood test or urine test or x-ray or MRI. That is basically concept of the patient. But here what happens is, the patient is having severe pain along with various other vague symptoms, but all the tests will be negative. So the family member will also will not trust them. They will say that they are making their everything is in their head, nothing is, all the tests are not, negative, and all the doctors is saying that everything is all right, why the patient is having pain. And they might think that it can be only somatization of the pain, or the pain is only in their brain and nothing. The patient is basically having like pretending that they are having pain. So these common problem patient usually face in case of fibromyalgia. Okay, so normally in case of fibromyalgia, we usually see this diagnostic tool where we go for the wide spread pain index and symptom severity scale. So here, this is the common chart which is given to all the patient who we think of is the fibromyalgia, and we basically we let the patient fill the chart by himself. So he or she will tick wherever there is pain. So if there is jaw pain, they will tick at the jaw, chest, abdomen, and neck. Look at this side. So everywhere they can have pain. Okay. So along with pain, they will also have other features like fatigue is one of the most common problem, and depending upon the severity of the fatigue, they will mark whether it's 0, 1, 2, or 3. Similarly, they will have very difficult time waking in the morning. So if they have this, they will also mark these tools are given to the patient to mark by themselves. Okay, they can have a memory or attention problem, and if it is present, then we'll tell them to give the scoring by themselves. And somatic symptoms will be there. Somatic symptoms mean the symptoms that I've already explained, like headache, dizziness, dry ear, dry like sensitivity, or gastritis, feeling of gastritis, irritable bowel like syndrome, joint pain, stiffness, and depression, anxiety, and like palpitation. These are all somatic symptoms. So depending upon how much is the somatic symptom, they will give the score. And finally, if the widespread pain index is more than equal to 7, and if the symptom severity score is more than equal to 5, then this is one of the it is suggestive of fibromyalgia. Or if the widespread pain index is 4 to 6, but symptom severity score is more than or equal to 9. So these are the two diagnostic this is the diagnostic tool we use for the diagnosis of fibromyalgia. So but we always have to rule out, like do some screening tests, like we have to rule out we have to do ASR to rule out like inflammatory arthropathy. Sometimes vitamin B12 deficiency will also have similar type of complaint, like fatigue, pain all over the body, cognitive dysfunction, burning, tingling pain, revolving pain. So this can be also a common problem in vitamin B12 deficiency. Or this can be also commonly problem of vitamin D deficiency. Well, the patient will tell of extreme fatigue, tiredness, pain all over the body, like memory impairment. So these are all common problem associated with vitamin D deficiency. And of course, thyroid deficiency will also have similar type of problem. So to level the patient fibromyalgia, these tests has to be done, and all of these tests should be negative, or most of these tests should be negative before diving into conclusion of fibromyalgia. So normally treatment modalities, usually the treatment patient does, we don't have actual cure of fibromyalgia. Basically the treatment is multimodal treatment. Normally medication like NSAIDs are given, like naproxen, aceclofenac, or other non-steroidal anti-inflammatory drugs are given to take care of muscular pain or skeletal pain. Duloxetine, FDA has approved duloxetine, pregabalin, and milnacipran. Those so these three drugs are FDA approved drug. So we usually start with duloxetine. If the duloxetine is not helping, then we'll go for pregabalin or milnacipran. And gabapentin and amitriptyline are also second line of drug in case of fibromyalgia. Physiotherapy is of extreme importance. Yoga, aerobic exercise, especially in the morning and night, are advised to the patient. If the patient have severe anxiety, depression, or if the fibromyalgia is of extreme nature, then we can also go for cognitive behavioral therapy. We have to advise the patient to go for healthy food and sleep habit. And can also go for advise the patient to use lukewarm water while taking bath. And if none of these procedures are helping, then we can also go for systemic desensitization. That means we are basically injecting continuous infusion of lignocaine with or without ketamine for 1 hour. And we usually do this for about 5 to 7 session. And with this also, with also the
So we can't hear you.
side picture, you can see a female patient came in the pain clinic with multiple body pain. Okay, so here, though the patient told me that pain was only 1 month duration, but on careful history taking, she was having this problem for last 3 years, and she was having pain in multiple site in the body, like upper back, lower back, and over to upper and lower limb all. She had tingling and burning pain in both of the legs and hand. She also had other symptoms, like she was severely fatigued. She had a hair loss, dry mouth, dizziness was there, headache was there, sun sensitivity was there, bowel and bladder dysfunction was there. She was having consistent palpitation, and she was having shortness of breath and cognitive dysfunction. And she was treated with a depression, with a diagnosis of depression 3 years back. And she was being treated as depression only for, and she was giving escitalopram for that. But nobody has told her that the fibromyalgia could be in the diagnosis. Okay. And in general examination there was tenderness in multiple area of the body. Whenever we see any patient with depression, we usually see PSQ score, and it was about 15. And thyroid function test, blood sugar and creatinine was done in that patient. And and my diagnosis was fibromyalgia with moderate to severe depression, and started with duloxetine and miltrazepam. So because of the severe depression that the patient was having along with fibromyalgia, we also we had put miltrazepam in this patient. And other tests like vitamin D, vitamin B12 and ESR was advised to the patient. She had these tests, but it was like 3 years old test. So I wanted to order a new test in this patient, and she was also advised to go for lifestyle modification, healthy food, like all the other things also. So this was one of the case of fibromyalgia. Another case was a fibromyalgia with multiple body pain for 4 years. But in addition to multiple body pain, see, this patient also had a multiple joint pain for 4 years. Okay. So on examination there was multiple joint pain as well as body pain in this patient, and she was diagnosed case of lupus for last 4 years. So here the main joint pain was because of the lupus, and the multiple body pain was due to the fibromyalgia, but she was only diagnosed as a lupus, and fibromyalgia was not diagnosed in that patient. So with the pain she came to the pain clinic. Okay. And she was under SCQ, disease modifying drug, and pregabalin. And on examination, she had multiple joint pain, upper back pain, and chest. These are the investigation that the patient had. ESR was slightly high, 26. CRP was normal. Panca was positive. That's why the lupus was diagnosis was there. Uric acid was normal. Vitamin D was deficiency was also there. So with the diagnosis of fibromyalgia with lupus, we started her into loxetine. And after 2 months of in the 2 month of follow with the test that we had ordered like ESR and vitamin D, because it was less, she was having excellent pain relief with just duloxetine. And she was under duloxetine, pregabalin, and SUQ. And uh, and it was taking care of the body pain as well as a joint pain. So the main the take home message of this case is lupus or inflammatory arthropathy are also commonly associated with fibromyalgia. Okay. And we basically try to put blame all the blame on lupus or inflammatory arthropathy for the pain. We never think that the patient might have a fibromyalgia along with lupus or inflammatory arthropathy, and then go for the definite treatment. With just addition of duloxetine, all the symptom in this patient was better. So she came with severe pain of NRS score of up to 7, but on her follow-up visit, pain score was about 2 to 3, and she was very much happy with duloxetine. Okay. Third case I just wanted to present was like 61 years male with multiple body pain. And here also he with this pain he had gone for multiple doctor, and all the doctor were giving him alprazolam and amitriptyline for the problem, and they didn't even diagnose this for a fibromyalgia. and and he was having multiple body pain for 10 years. The pain was gradually on onset, and he also had key point was fatigue, anxiety, sleep disorder, memory problem was there, and mainly vivid dreams were also there since long time in this patient. And he was hypertensive, and there was some problem in the prostate. He was taking amitriptyline and alprazolam, but this was not relieving his body pain. And here the symptom severity score was like 9, and widespread pain index was 10. So with this like diagnostic tool, we diagnosed him as a fibromyalgia. And since the patient was already taking amitriptyline, instead of duloxetine we gave him pregabalin 75. And on the follow-up visit he was having a very good pain relief. So this was one of the case of fibromyalgia where we usually where the patient usually is diagnosed as a somatization of the pain, or or like the patient is not having any pain, but he or she, the family member will think that they will have a false belief of pain. So actually in these cases we have to educate the family also that this fibromyalgia is a real disease. Patient usually will have pain, though it is not seen by our naked eye. There can be pain in multiple area of the body, and all the tests in this condition can be normal. Okay, so this is basically a diagnostic tool that we used for the diagnosis. And another case is also of multiple body pain for 8 months of a female of 58 years old. Here you can also see there is a multiple body pain. Here pain was in the muscle as well as in the joints. Okay, and pain was deep aching in nature, tingling burning pain was there in the leg. She had fatigue, headache, sleep disturbance, hair loss, digestive problem, urinary problem, cognitive dysfunction, irregular menses, memory issues were there. And she she was diagnosed as a anxiety and depression, and she was giving sodium valproic acid 500 milligram and clonazepam for for this patient, and they were diagnosing this patient as anxiety and depression. But they never thought that anxiety and depression can be a part of fibromyalgia, and it can be a part of whole spectrum of disease. So on examination there was tenderness in multiple area of the body, uh, and the diagnosis of fibromyalgia was given, and duloxetine was added in this patient. And we also sent the patient to see vitamin B12, D, and THS and ESR, because these are the markers that we have to see. And she was ordered to follow up after 1 month, and in 1 month her pain, 50% of the pain subsided, and she was very happy with just with one drug. And we basically remove valproic acid and clonazepam after starting duloxetine. So here we can commonly diagnose this as just anxiety and depression. Okay, so here fibromyalgia could have been missed in this case. So another last case I want to present is a female of 20 years with similar problem, multiple pain in body pain in multiple area for almost she said almost 20 years. Okay, so 56 years, 20 years, deep aching pain with tingling, hair loss, dry mouth. There was tearing in the eyes, fatigue, deep sleep disorder was there, cognitive impairment was there, constipation, frequent urination at night, anxiety, palpitation was there. And she was already diagnosed as a fibromyalgia in India. She had come to Delhi in Max Hospital, where she was diagnosed as fibromyalgia. And she also had a hypertension, migraine, and cholecystectomy was already done. And she was already in duloxetine, and her lab test was this. You know? So here the main motto of this presentation is, sometimes if this conservative management fail, we can go for systemic desensitization of patient. Okay, so here if the normal duloxetine or pregabalin or other medicine is not relieving the pain, and in these cases in fibromyalgia we can go for a systemic desensitization. And thus she was very much depressed, because every time she used to go to doctor, only the dose of duloxetine was increased and pregabalin was increased, and she was in so much stress that she, because of frustration, she used to stop all this medication. Okay, but we planned her to go for systemic desensitization, and after this case was seen just now in November 26. Okay, so our plan is to go for systemic desensitization in this patient, about 5 to 7 sessions, to decrease the pain, and then only the duloxetine and pregabalin and these drug will act in the regular or small doses. So this is a severe case of fibromyalgia, where the treatment plan is systemic desensitization rather than increasing the duloxetine or pregabalin or other medicine that the patient is having. Okay, okay, thank you, sir. So this is the third case, sir, fibromyalgia. So any question in this fibromyalgia? I
Yes,
wanted
if
to.
any questions are there, we can go ahead. And also, I could find out the SI joint radio frequency procedure. So, as was asked by Dr. Shuman. So, after completion of these discussions, we also have some time. We can go ahead with the SI joint radio frequency procedure. I'll be demonstrating that. I'll be showing you the video. Okay, but before that, fibromyalgia is one condition which can mimic any conditions, and it has been compared with the blind people examining an elephant. So if they don't know the elephant, if they touch the wall of the elephant abdomen, he'll be thinking that elephant is a wall. If somebody is touching the leg, he'll be thinking that elephant like a pillar. So same way, fibromyalgia, if we don't know the disease condition itself, we might be comparing it with any other common conditions. It can be confused with the rheumatological conditions. It can be confused with the the radiculopathy, prolapse disc. It can become confused with the psychological disorders. So a lot of things can be confused. So you have to make a diagnosis, and the most important way to make a diagnosis is the fibromyalgia diagnostic tool by the American College of Rheumatology. So this has been modified by several times. Initially, the first it was published in 1990 when the tender point count was the diagnostic criteria. And later on in 2010, the diagnostic criteria was changed, and then this WPI and symptom severity scale was introduced, and there was no need of palpating the tender points. And in fact, earlier, we can remember in my early days of practice, when the fibromyalgia diagnosis was made on tender point calculations, when you used to press the tender points, patient used to complain that, okay, my pain has increased a lot after examinations. So nowadays, the tender point calculation is not needed. You just need to ask which area of the patient is painful, like in the picture, you mark it and count it, and then see whether the fibromyalgia diagnosis is positive or not. So this is how the fibromyalgia diagnosis has to be made. I always tell our fellows that if anybody have pain in more than 3 areas, then always rule out fibromyalgia, because this is so common. The estimated about in a pain clinic, every fourth or fifth patient is fibromyalgia patient. So it is such a common conditions. And unless you know the disease, unless you know how to make a diagnosis, we will be always misdiagnosing it. So any questions regarding this, you can ask Siris or me.
Sir, about systemic desensitization.
Siris, can you answer this question? Systemic desensitization, what is it?
So systemic desensitization is usually done, like I remember sir telling in class, like one example, monkey's example. He used to give us the example of monkey. Okay, the monkey is in the like up in the tree, and we'll not be able to tame that monkey. We have to bring that monkey down, and then only we can train that monkey. So similarly in fibromyalgia also, if the pain score is too high, just by increasing the dose of the drug like duloxetine and pregabalin will not help. We will not be able to control the pain. In these patients with severe fibromyalgia, what we can do, what sometimes has to be done, is that sometimes we have to infuse like lignocaine, or as we know, lignocaine has an analgesic effect. They have a membrane stabilizing effect, and so does the ketamine. So we usually infuse the patient 1 hour every day for 5 to 7 sessions with basic monitoring like heart rate, blood pressure, saturation, everything is monitored. And patient comes to the clinic for 1 hour, and we, with the infusion pump, we gradually increase the dose of lignocaine and ketamine. We usually start with 3 mg per kg dose, and in second day we'll start with 3.25 mg per kg dose, and gradually escalate the dose of the lignocaine, and infuse the patient lignocaine, calculated volume dose of lignocaine in a patient every day. So this drastically reduces the pain. Okay, that means monkey is now down near at the ground, and once the pain is controlled, then the normal dose of duloxetine and pregabalin works very nicely in this patient. And I have seen in my fellowship days, and I've also started doing this systemic desensitization in like about like 15 or 20 patient fibromyalgia. 1 or 2 patient will come in every 6 months for desensitization, and this is a this is an excellent technique to decrease the pain, initial severe pain of the fibromyalgia, and later on, once the pain is controlled, then the normal dose of duloxetine, that is 20 to 30 or 40 milligram of duloxetine, will be able to control the pain. So this is regarding the systemic desensitization.
So can we go with the trigger point injections as well, or just
So trigger point injection is not the treatment for the fibromyalgia. Trigger point injection is the treatment for the myofascial pain. If the myofascial pain is coexisting with the fibromyalgia, then you can go ahead with the trigger point injection. Otherwise, trigger point injection have no role if there is no myofascial pain in fibromyalgia. Fibromyalgia have the tender points where the trigger point injection or local anesthetic steroid injection. These are very much obsolete way of treatment. So don't think of any trigger point injection in pure fibromyalgia. Do it only when there is presence of myofascial pain. Okay. And always another thing, remember, many old-fashioned, physicians still give injection of the steroid injection in the muscle. Never give steroid injection in the muscle. I also have given 20 years back, written in the history book nowadays, we used to give the steroid injection in the muscle. Steroid injection should not be given in the muscle. It causes the muscle fibrosis. Contractility of the muscles will be reduced. So don't give any steroid injection in the muscle. You can give the local anesthetic in the muscle or dry needling or dextrose injection, but not the steroid injection.
So,
Yes?
so
Many
can
patients
we?
are
Yes, one by one. We'll be answering everyone. Don't worry. Yes, please.
Bindu,
Shall I
go ahead.
answer?
Okay, Ridhima, you can go ahead.
Sir, many patients are coming post dengue and chikungunya, sir, with small joints pain, sir, not responding to any pain medication. So what should be done, sir? The
So
small
this is
joints, sir,
not
like toes and
this
finger.
is not just for the chikungunya. Even
Yes,
during
sir.
the corona period, many people came with a joint pain, musculoskeletal pain. So
Yes, sir.
exact reason for this musculoskeletal pain after the viral fever is not known, but it is considered to be as a autoimmune disease which is affecting the musculoskeletal system, the joint, the synovium. Sometimes even the effusions are there. So this
Yes, sir.
patient, it can be compared like that of the reactive arthropathies. If you are looking about the spondyloarthropathy is a basket of disease where there is ankylosing spondylitis is one, psoriatic arthritis is another is your reactive arthropathy. Reactive arthropathy normally after some infective disorders. It can be diarrhea, it can be chest infection, or sometimes it can be after the viral fevers as well. So post-chikungunya joint pain is similar to that, though it is not typically classified as a reactive arthropathies, but it is similar to that of the reactive arthropathies. Normally, this is self-limiting. We have to treat these conditions with a non-steroidal anti-inflammatory drug and sometimes steroids, oral steroids, or sometimes steroid injection in the joint. These are the ways to treat these patients. If there is
Then the
multiple
small
joints,
joints, sir.
I understand. If it is, that is what I'm trying to tell you.
Mhm.
Small joints, if it is one or two or three joints, you can go for the intraarticular injection. But if it is multiple joint, you cannot give injection in so many
Yes,
joints.
sir.
So the first condition is again your non-steroidal anti-inflammatory drug like diclofenac, like ibuprofen, like the aceclofenac. The other drugs what you should be naproxen. The other drugs you should try fast for a few weeks. If not, adequate relief, or if the patient having the side effects of these drugs, you can think of giving some steroid also for a few weeks. Normally, most of the patients subsides with that. If not, then, and if the ESR, CRP, and all these things are persistently elevated beyond the 6 weeks or 8 weeks period, then you can start the disease-modifying drug like sulfasalazine or hydroxychloroquine. So this has to be considered later on. But initially, most of the patients respond nicely to the NSAIDs and oral steroids. And sometimes intraarticular steroid if large joint or very few small joints are involved.
But in diabetic patients, we cannot give oral steroids, sir.
So in that situation, you have to rely on the NSAIDs only, analgesics only, and you have to
NSAIDs
wait.
only.
There is
Okay.
basically no treatment as such unless waiting, because these are spontaneously self-resolving. And
Okay.
if the patient is still having some pain beyond 3 months, also we see this kind of patient as well. That patient
sir.
was having the chikungunya 6 months back, and since then the pain has started. In that situation, you can think of adding the duloxetine, and you have to think of adding the disease-modifying drug like sulfasalazine or hydroxychloroquine.
Okay, sir. Thank you, sir.
So, my question is, sir, this fibromyalgia is a neuropathic pain condition, sir. So, is there any role of carbamazepine also in this disease, sir?
If we are looking about the US FDA approved drug, so the US FDA approved drug is pregabalin, duloxetine, and venlafaxine. They are the three drugs, milnacipran, sorry. They are the three drugs which are approved by the US FDA for the treatment of the fibromyalgia. But other supportive drugs are amitriptyline, gabapentin, the tramadol, tapentadol. These are the other few drugs which are also effective in the fibromyalgia patients. Venlafaxine is another. But the carbamazepine is an anticonvulsant, so it can be used if the other drugs don't have such much effect. If the other drugs have some side effects, you can try carbamazepine. But keeping in mind, carbamazepine side effects profiles are little, safety profile is little less safe than the gabapentin and pregabalin. So if you are using carbamazepine, you can use it. You can try it if your other drug has failed, first line management drug has failed, then you can try it. But keeping in mind that if you are giving this drug, you have to monitor it and the blood parameters has to be done. Okay?
So
But it should not
these
be the first line drug. It must not be the first line drug.
so
First line
so
drug should be the US FDA approved drug. Means pregabalin, the duloxetine and milnacipran. These are the 3 US FDA approved drug.
Sir, on that note, sir, the 61-year-old male case is there where the patient was already on amitriptyline and pregabalin is added. Can we even change that amitriptyline to duloxetine and
Yes, why
pregabalin?
not? You should try it. You can try it. The first line drug, again, I am telling you, the pregabalin, duloxetine, and milnacipran. Milnacipran, unfortunately, earlier I was using so much of milnacipran in my patients. But nowadays, milnacipran is, very much not available in Indian market. That is one of the very difficult situations that if one antidepressant is not working, you cannot switch over to the another antidepressant which is US FDA approved for fibromyalgia. But definitely, amitriptyline, nortriptyline, these are the second line drug which can be tried in the fibromyalgia patient.
So one suggestion, sir,
Yes.
from your side. I was planning a study like a drug comparative study in fibromyalgia cases like lignocaine versus ketamine versus combining ketamine and lignocaine like that. But I searched lot of literature. I couldn't find any drug comparative study kind of thing.
You can go ahead. Today only, I just before this class, I posted one thing that the one of the very difficult situation for the many of the practitioners in the private practice. If this message is for all of you, that they don't have the institutional ethical committee, because ethical committee permission and the clinical trial registration nowadays is mandatory for any publications acceptance by the any journal. So if you are having your own institutional ethical committee, it's fine. Otherwise, you can plan a multicentric study with our clinic where the ethical committee permissions can be taken from our clinic. So this can be a good study. If you wish to have it, you can
Yes, sir.
either you can go ahead with your own ethical committees, or you can collaborate with any one of us and you can go ahead with it.
Yes, sir. Actually, we
I
are
always
doing
tell, don't just copy and follow what has been there. Try to think something out of box, try to think something innovative, try to think something new and publish it, establish it. That is the way to practice. Just don't become a very nice copier. People will be telling you a very nice copier. Practitioner is a good practitioner cannot be just a copier. It must be having some more new innovative ideas, and that can be established only by good publications. So it's good. I'll be encouraging it. And you can go ahead with your own ethical committee, or you can collaborate with us.
Yes, sir. I was doing ketamine regularly, but now I wanted to compare that with lignocaine and also lignocaine with ketamine. For that,
Lignocaine has the more the published literature rather than the ketamine. Lignocaine is having the better publications, but still ketamine also have few publications are there.
yes, sir. I the
Combinations are
psychiatric
also
journal
there.
I
Combinations
found.
also, sometimes they use the combinations also. Lignocaine plus
Yes,
ketamine combination.
yes, sir. But I couldn't find a comparative literature
You
anything
go
that.
ahead. You go ahead. It will be a very good study. You go ahead.
Okay. Okay. Any papers you have in your mind that you can suggest me for doing this kind of study?
Uh, okay. You first write your plan. Do you have your ethical committee, or who is this? Devi Monohari you are talking?
Bhanushri, sir.
Do you have your
Sir,
ethical
I'm
committee?
attached with the institute, and I also have my private practice. I'll do with my institute. I was planning to do
So
with
then you
my.
then you in your hospital, in your institute, there must be somebody who are very fond of research, you must be getting somebody in there in the ethical committee. You contact with them and you find out similar kind of papers. So similar kind of papers where that few drugs has been compared, and I always tell these things. Choose some of the, after searching literature, choose some of the full article, read it nicely, and try to the follow that path. I should not be saying copying. Initially, when you are publishing, then that time you should be doing this way. Gradually, you will be learning more and more, and then there will be no problem at all. So you first search and find out some good literature, and you go through that, and you can follow these things. Comparing the different drugs are not uncommon. These kind of studies are there.
Yes.
Not exactly
Yes.
the IV, but different drugs, oral drugs, different drugs comparison, how much efficacious it is. So this kind of studies are, a lot of studies are there. So you can go ahead and you follow the typical, the steps, how to go ahead with it and format.
Okay, okay, sir. Thank you, sir.
So can we give the combination like pregabalin, duloxetine combined drugs, sir?
Yes, many times we give it. And nowadays combination drugs are also available. Where you need not, because it will be more convenient for the patient not to take the two drugs separately together combinations. So you can go ahead. Many patients will give it combination.
Sir, we can start all the three together, like pregabalin, duloxetine, milanocyprin, or one by one we have.
No. You can combine the one anticonvulsant with one antidepressant. Don't combine two antidepressant together. So pregabalin and duloxetine you can combine. Pregabalin with amitriptyline you can combine, but don't combine one amitriptyline with one pregabalin, with one duloxetine, or with a milnacipran or venlafaxine. Don't combine this kind of drug. There will be serotonin syndrome. This is called serotonin syndrome because all of them are elevating the serotonin level, and there can be side effects. So even sometimes what happens, somebody is receiving some SSRI, say for example escitalopram is so common, escitalopram, or some other kind of antidepressant drug. So what we have to do, you have to taper up that drug and you have to increase the dose of the duloxetine or the other drugs what you are prescribing. So don't combine two serotonin elevating drug together. So it's not a good idea to combine duloxetine along with the milnacipran. Either give milnacipran or give duloxetine.
The duloxetine with amitriptyline also should not be combined, sir.
Obviously, because both
Okay.
are antidepressant.
Sir, and amitriptyline is better or nortriptyline is better, sir?
Both are
Like
similar.
there are many.
Both are tricyclic antidepressant, but duloxetine, the nortriptyline is less sedative than your amitriptyline. So if the patient is complaining that, okay, my sleep is disturbed, I don't have a good sleep, I need to take the sleep medications, then your choice will be amitriptyline. And if the patient is telling, okay, in the morning I have to prepare my little boy for his school, I have to rise early morning at 5 p.m., then you should not give the amitriptyline, you should give the nortriptyline. So in that way, you have to think which one is beneficial for the patient. But both the drugs are almost similar, amitriptyline and nortriptyline.
Thank you.
So duloxetine night dose, many of my patients are complaining that decreased sleep.
Yes, some patients complains of the more sleep. Like my wife, she takes duloxetine and he takes, okay, when I take duloxetine, lot of sleeps. And some patients complain disturbed sleep, not a good sleep. So both can happen in the duloxetine. So normally these patients, over the period of time, normally this uneasiness either of excess sleep or less sleep are getting well tolerated. This is normally happens. But if still it is disturbing, you can switch over to the venlafaxine.
Okay, thank you, sir.
We can switch over to what did you say, sir? I didn't get.
Pardon?
If there is sleep disturbance. You
Pardon?
told some other drugs, sir. If
Some
they
other
have sleep
either
disturbance.
milnacipran or venlafaxine. Okay. Any more questions?
Yes, sir.
So are you ready for the SI joint RFA? 5-7 minutes, 5-10 minutes. This was
Yes.
for
Yes.
Suman.
Yes, sir.
Yes.
Okay. I was searching and I fortunately got these videos. So let me share with you.
I'll stop this here, sir.
Okay.
Sir, I
Sir.
want to ask
Yes. Yes, I can't hear you.
Sir, just out of league question. Sir, just out of league question, sir, is for PIBD patient having psoriasis, is the steroid, matlab, steroid injection is is there any contraindication
No, no,
or
no.
we can go with it?
Steroid is not contraindicated. In fact, steroid can be given in the psoriasis also. Steroid
Yes, sir.
ointment is sometimes
Patient is
given.
having, sir, generalized psoriasis, but
It
at
is not
back
a
there is
contraindication.
one trunk. Okay,
It
sir.
is not a
Okay,
contraindication.
sir. Okay. Okay. That's what. Thank you, sir.
So till when we can assess this video, sir, to reread or
All these videos can be accessed till 31st of December.
just 31st of December, sir?
Yes, during the course, but even after the 1 week after the course also you can access it.
Okay.
But many of the videos, particularly these clinical PAL videos, I feel this, many have not attended this course, but I feel this kind of discussions is very important when you are going the practice, because you know the how to make a diagnosis, differential
Yes,
diagnosis, complications, mistake in the diagnosis. These are very important part in the clinical practice. So what I'll be making, many of these videos I'll be available, make available for the future things. Okay,
thank you, sir.
so don't worry, I'll be doing something.
Thank you.
Okay. Okay, so first we should know what is the innervation of the sacroiliac joint. So sacroiliac joint is innervated both by the dorsal rami branches as well as the ventral rami branches. Ventral rami branches comes from anterior part of the SI joint, and 20% of the nerve supply, approximately 20%, are from the ventral rami branches, which can never be accessed. Dorsal rami branches are almost 80%, and most of them comes from the S1, S2, S1, S2, and S3 foramens. And apart from that, the few branches comes from the L5, which is resting over here, over the ala of the sacrum, and sometimes branches can come from the S4 as well. But mostly the innervations are the lateral branches. They are the lateral branches, and which forms a network with the lateral sacral crest. This is a lateral sacral crest, and where the network is there, and from that network, the medial part of the sacroiliac joint, it is getting innervated from this network. So when you are planning to denervate the sacroiliac joint, we cannot access the ventral rami branches, which already I told you. So dorsal rami branches, what we can do is this S1, S2, and S3 foramen. We start placing the needle from the upper part of the S1 foramen on the lateral side, the space between the sacral foramina and the iliac crest. So let me start annotation. So these are the foramens. So these foramens, the lateral part of the foramen and the iliac crest, this space between these two, we have to find it out. And you have to place the needle. The first needle will be along the line of the upper part of the S1 foramen, and the lowest needle should be the lower part of the S1 foramen. This additional needle placement is your optional. So you have to place the needle at around 1 centimeter distance, and normally 5 to 7 needles need to be placed. These are all for the lateral branches, which comes from the lateral part of the sacral foramina. Apart from that, we need to place another needle at the junction of the ala of the sacrum and the superior articular process at this to ablate the medial branch of the L5. L5 medial branch of dorsal rami comes like this, and branches come there to join this network. So this network of the nerves is there over the lateral sacral crest, from where the nerves goes to supply the sacroiliac joint. So with this basic anatomy, let me start the video. So this is videos has been fast forwarded, and that is the reason why this movement. This movement is not anything. This is because respiration movement, but because I have fast forwarded it, it is looking like a convulsive movement. So these are not convulsive movement. So first we are doing on the left side. So this is the area. These are the sacral foramens. So these are the sacral foraminas. So our needle, and this is the iliac crest. So this space between this and this, we need to place needles from here to here till the upper part of the SI joint to the lower part, lateral side of the S1, S2, S3 foramen. So these needles are placed. Here we have placed the 6 needles, and we'll be doing the stimulation. We'll be first seeing with the lateral view. Lateral view, it will be like this. And in the lateral view, your needle should not cross the posterior sacral plate. So you should not cross that plate. And not into the sacral foramen, sacral, the canal. And we have to check by the lateral view and also by the AP view. The needle should be almost parallel. Some needle and the distance between these two needle should be approximately 1 centimeter. So after we are correcting the needle placement, and then we are going for the stimulations. And after doing the stimulations, we do the lesions, strip lesion continuously one by one. So this patient was having the bilateral pain, and after completing it on the one side, we give a little bit of the steroid injections, and then we go to the other side. So this is the local anesthetic before doing the radiofrequency ablations. So we are doing the bipolar lesions here. Bipolar lesions having the advantage that you can together go with the 2 lesions together, and you can have a larger lesion, larger strip lesions. So sacroiliac joint, either the bipolar radiofrequency or the cool radiofrequency. Cool radiofrequency can also create a large size lesion. These are the 2 recommended lesions, recommended procedures to have a large size lesion. So first we did on the left side, and then after completing, we did on the right side. So almost similar procedures. So CM placement will be contralateral oblique to create the space between the lateral sacral part of sacral foramina and the iliac crest. That can be increased if you are making a contralateral oblique. So we made the contralateral oblique and did it. After completion of the procedures, we injected the steroid and we take it out, and then we put the needle on the right side in the same fashion. And after completing that, we are giving the little bit of steroid injections. The same way, in this side, we have placed the 5 needles. And needle should be parallel. It should be checked both by the AP and the lateral view. And the needle should be placed between the sacral foramina and this. And then we are going for this is for the L5 medial branch. So this is the ala of the sacrum and this junction. And here the CM should be your caudally tilted. From the caudal side, we should be taking the needle in the tunnel vision. The CM should be caudally tilted up around 10-15 degree. And then this area, this is the target area. This is the area where you should go. So the lateral branch of all sacral nerve roots, S1, S2, S3, and the medial branch of the L5, where the target will be at the junction of the ala of the sacrum and the superior articular process. So this is one side, left side needle was placed. And then we'll be placing the needle here on the right side also, because patient was having the bilateral SI joint pain. We are checking by the lateral view, 2 sides, both the needles are placed. And then we did the multi-channel listening. Multi-channel listen is you are doing the lesion simultaneously at both the needle. It's a multi-channel lesion means 2 monopolar lesion together is your multi-channel lesion. So you are doing the 2 monopolar lesions, medial branch on both the side, because the patient was having the bilateral pain. So after that, again, we'll be giving the steroid injections, and that completes the procedure. Okay. Understood? Where is Suman? This video was for you only.
Yes, yes, sir.
Okay.
Yes, sir.
Okay.
Thank you so much.
Okay. So thank you, everybody. I hope no more questions are there, and we'll be
There
meeting.
is small doubt, sir.
Yes. Yes. Tell.
Sir, when we are stimulating the patient in the SI joint, this thing, where will the patient exactly tell the sensation, sir? Like,
Patient will be having the sensations in the back, lower back or buttock pain. Patient should not have a radiating pain down the leg. In that situation, you have to understand that you are close to the nerve roots. But normally that do not happen. It is not easy to go through the foramen and to go to stimulate. Unless you are going inside the foramen, then there will be no radiating pain. The posteriorly, the dorsal rami branches don't have the important supply. Only some supply in the upper sacral nerve roots is going to the multifidus muscle. But apart from that, there is no important motor supply or sensory supply of these fibers. So the stimulation will be around the buttock area. Okay.
okay,
And patient should not have any motor contraction, or patient should not have any contraction of the leg muscles. Right?
okay, sir.
Okay. So
Excuse me, sir.
yes.
Sir, what if the patient is unable to lie prone, like obesity and all? Like if he's having, like, which position is preferred in that?
Prone position
Lateral
is always
can we?
preferred. Prone position is always preferred. Lateral you can do, but you have to then, what you have to do? You have to make in the lateral view to take it as an AP view. Sometimes we do that. Sometimes this is not just for the sacroiliac joint. Sometimes we do it for the, the more commonly for the lumbar procedure, some other procedures where patient cannot lie prone. Then we have to take it as a lateral view as a AP view, and AP view as a lateral view. So in that way you have to go.
Oh, okay, sir.
Or you can take the help of the ultrasound also. But the technically it becomes difficult to do the procedure. Okay, any more questions?
Sir, in Daradia YouTube channel, there is a plantar fasciitis PRP video was not there, sir. Can you post it?
Plantar fasciitis, PRP video. Okay, very recently we have done it. Let me check whether we have done the videos or recordings or not. If it is recording is done, I'll be posting it. It is very easy, not a difficult one. Or otherwise, if it is not available, then I'll be showing you on the 3D anatomy and I'll be telling you how to introduce the needle. Okay?
Yes, sir. Thank you.
Okay. Okay. Good night for today.
Thank you, sir.
Good night, sir.
Okay,
Thanks.
good night.